Good afternoon, everyone. My name is Michael Fan, and I'm one of the PGY1 residents over in the pharmacy department. And I'm here today to give you a topic discussion on headaches. The title of this topic discussion is You Give Me a Headache. For this presentation, by the end, I want you all to be able to evaluate the different types of headache disorders, be able to create an individualized treatment plan, be able to select second-line options, and be able to develop a plan to prevent reoccurrences. So let's get started. Headaches. Here's some background information about headaches. In about a 3-month span, 1 out of 6 people in America will experience a headache. 1 out of 10 men will experience a headache, and 1 out of 5 women will experience a headache. So headaches are 2 times more prevalent in women. The highest prevalence of headaches are in Native Americans, and the lowest prevalence of headaches are in Asians. Presented are the 3 types of headaches. We have tension headaches, migraines, and cluster headaches, and they're all unique in their presentation. Tension headaches are bilateral, while migraines are unilateral. Furthermore, cluster headaches are defined by the frequency of which they occur. They come in a cluster, and they are usually located around the occipital region. So let's go into tension-type headaches first. Tension-type headaches are the most common type of headache disorder. Most people who get tension-type headaches, however, do not seek medical attention, as these are not severely debilitating headaches. Tension headaches usually range from mild to moderate in severity. They're most common in women, and the highest incidence occurs throughout the ages up until 40, and then it decreases in incidence. The pathophysiology behind tension-type headaches is that they're caused by a sensitization to the pericranial nociception. Common causes of tension-type headaches include environmental factors and genetic factors. As I mentioned before, they usually present as a mild to moderate, non-pulsating bilateral pain. They usually present in the top image, which is a band-like tightness, or the bottom image, which is a pressure around the head. Tension-type headaches are classified based on frequency. Infrequent tension-type headaches occur less than 1 day a month. Frequent tension-type headaches occur 1 to 14 days a month. And chronic tension-type headaches occur more than 15 days every month. For the goal of treatment for tension-type headaches, we want to first relieve pain, but do so in a way that avoids medication overuse or dependence. Furthermore, the treatment of tension-type headaches are more effective when you address the symptoms early on. For tension-type headaches, we have non-pharmacologic and pharmacologic options. We want to try our non-pharmacologic options first, which includes ice packs, massages, relaxation therapy, and cognitive behavioral therapy. For our pharmacologic options, we have simple analgesics such as Tylenol, aspirin, or NSAIDs. We have our caffeine combination products such as Excedrin, and then we have triptans. Triptans are unique in the treatment of headaches in general, so I will go over them on the next slide. Things to avoid in tension-type headaches are your butalbital-containing products, your opioids, and your muscle relaxants. And that's because, as I mentioned before, one of the goals of treatment is to prevent medication overuse headaches, and these medications have the highest risk of dependence and abuse. So let's go into triptans. Triptans are serotonin 1B, 1D agonists. They work on the serotonin receptors to cause a vasoconstriction and a decrease of inflammatory markers. Triptans have a high variation of response, which means that if you fail one triptan, you can usually turn to a different triptan. Triptans are relatively safe, and they can be used alongside NSAIDs for an additive effect. Lastly, triptans are contraindicated in patients with ischemic heart disease, Wolff-Parkinson-White syndrome, or a history of stroke or TIA. And that's because, as I mentioned before, the serotonin receptor causes vasoconstriction, and the 1B, 1D receptor is located on your vasculature. So in patients who have vascular stenosis, further vasoconstriction can actually be detrimental or even fatal. Presented on this slide are each of these triptans with a little information about all of them. I'll give everyone a copy of this presentation, and you can examine it in your own free time. The biggest takeaway point from this presentation, from this slide, is that some of these triptans have multiple dosage forms, and each of these triptans have a maximum dosage per day, and this is to prevent medication overuse headaches. On this slide, I summarize the key points for each of the triptans. We have our 7 triptans, our sumatriptan, zolmitriptan, rizatriptan, naratriptan, almotriptan, elatriptan, and frovatriptan. And our last 3 triptans, almotriptan, elatriptan, and frovatriptan, are available only by brand name. Sumatriptan has a little Tennessee symbol next to it, indicating that it's on the TennCare formulary. So this is your go-to medication for those who are restricted by this formulary. Furthermore, the needle indicates that sumatriptan is available in a subcutaneous formulation. Sumatriptan and zolmitriptan are available in an intranasal formulation, and zolmitriptan and rizatriptan are available in an orally disintegrating formulation. I bring this up because the subcutaneous, intranasal, and orally disintegrating formulations are more effective and have a quicker onset, so you want to use these in patients with more debilitating headaches. Furthermore, sumatriptan, naratriptan, and elatriptan are contraindicated in patients with severe hepatic insufficiency, and naratriptan and elatriptan are contraindicated in patients with severe renal insufficiency. Furthermore, naratriptan has clinical data behind it to support its use in patients who have failed sumatriptan. So if sumatriptan was your first choice for your patient and they have not responded, I would advise using naratriptan next. Now let's go into the prophylaxis of tension-type headaches. Not everyone gets prophylaxis for tension-type headaches, as these are not usually chronic headaches and that these are not usually severe headaches. So people who get prophylaxis are people who get frequent or chronic occurrences, or if a tension-type headache is known to last over 3 to 4 hours. We first want to visit our non-pharmacologic options, such as a reduction in stress or a reduction in red wine intake. For our pharmacologic options, I've included these medications in the order of level of evidence. The most data behind the prophylaxis of tension-type headaches are in low-dose tricyclic antidepressants. These are your amitriptyline and your nortriptyline at a 10 milligram dose at bedtime. Next, we have mirtazapine and venlafaxine, which have shown to help decrease the incidence of tension-type headaches, even in patients without depression. Lastly, we have topiramate, gabapentin, and tizanidine, and these 3 do not have randomized controlled trials behind them. However, they're great third-line options if you need it. And with that, I would like to go into migraines next. Migraines are more recurring headaches, and they're usually severe enough to interfere with daily function. Migraines are usually associated with nausea, and they're also more common in women than in men. The usual onset for migraines are people between the ages of 30 and 49 years old. The pathophysiology behind migraines is very important to understand, as this will direct a lot of our treatment options. Migraines are caused by a brain neural dysfunction that results in overactivity of the trigeminal vascular system. Overactivity of this trigeminal vascular system by the sensitization of neurons can actually cause chronic migraines. So for the treatment of migraines, we want to provide something quick and effective to prevent them from becoming chronic. For the pathophysiology of migraines, we also have to understand the role of serotonin. And serotonin blocks the transmission of this trigeminal vascular system. As such, for the treatment of migraines, we have serotonin agonists. Furthermore, we have to understand the role of calcitonin gene-related peptide, also known as CGRP. Unlike serotonin, CGRP propagates this trigeminal vascular system. As such, for the treatment of migraines, we have medications known as CGRP antagonists. Our goal of treatment for acute management of migraines is to provide rapid treatment, restore the ability to function, and provide something that's cost-effective. Being cost-effective is important as migraines are more likely to be chronic, and as such, you want to provide something that the patient can afford in the long run. For the long-term management of migraines, we want to decrease the frequency, decrease the severity, and overall improve quality of life. And for the prophylaxis of migraines, we want to avoid triggers. First, let's talk about abortive therapy. For abortive therapy, we have options such as simple analgesics, combination products, these are your caffeine combination products, and even we can consider butalbital combination products if the migraine is severe enough. We have triptans, ergots, a new medication that came on the market called lasmiditan under the brand name Rayvow, and we have antiemetics. Antiemetics have actually shown to decrease the nausea associated with migraines as well as the pain and the duration. Since we haven't gone through ergots, I want to briefly go into ergots. Ergots work by activating the serotonin 1B, 1D receptor, much like triptans. Since they both activate the same receptor, we should never use them together. And that's because causing vasoconstriction that's additive can be very detrimental. Ergots are often used in combination with caffeine or analgesics, and ergots for the most part have more adverse events than triptans. The biggest adverse event that I consider with ergots is that they cause significant nausea, and this can be severe enough to warrant the use of metoclopramide at a 10 milligram dose if the patient is known to have a reaction to ergots. Furthermore, you should avoid ergots in patients with coronary artery disease, peripheral vascular disease, hypertension, and hepatic or renal insufficiency. Lastly, they're contraindicated in pregnancy. Based on everything I just presented, this is why ergots are usually reserved for last line option. There are two ergots on the market. The first ergot that I would like to go into is ergotamine. Ergotamine comes in a sublingual 2 milligram tablet. You may repeat this every 30 minutes, but you have a max dosing of 6 milligrams a day or 10 milligrams per week. You should avoid ergotamine in patients with a prolonged aura, and there's a lot of question about its efficacy. Furthermore, they can cause rebound headaches. And as such, ergotamine is usually one of the last line options that I resort to. The other ergot is dihydroergotamine, and this is a friendlier version of ergotamine. It comes in an IV, an IM, a sub-Q, and an intranasal formulation. And most of these formulations come in a 1 milligram dose, except for the intranasal one. I've listed all of their max dosing as above, and the key point about dihydroergotamine is that they have a better safety profile than ergotamine. It does not cause rebound headaches, and dihydroergotamine does not cause dependence. Next, I want to go into lasmiditan, also known as Rayvow. Rayvow was approved in October of 2019, and it's also a serotonin agonist. However, it works on the 1F receptor. By being a serotonin agonist, it causes a decreased stimulation of that trigeminal vascular system. However, the 1F receptor is not located on your vasculature. As such, the 1F receptor does not cause vasoconstriction. The role of therapy for lasmiditan is in those patients who have ischemic heart disease or any sort of stenosis. Lasmiditan comes in a 50 milligram, 100 milligram, and a 200 milligram dose, and the max dosing is one of any of these dosage forms within 24 hours. Furthermore, the efficacy of lasmiditan has not been studied in patients who receive more than 10 doses per month. The biggest side effect for lasmiditan is dizziness, drowsiness, and fatigue, and this is severe enough to warrant caution in the use of operating heavy machinery and the use of driving. In the clinical trials, they looked at the 100 milligram and the 200 milligram dose of lasmiditan and compared it to placebo. Compared to placebo, which showed a 15% decrease in headache pain-free days, the 100 milligram dose showed an increase of 28% decrease in headache pain-free days. Once you move up to the 200 milligram dose, that showed a 32% decrease in headache pain-free days, which is not that much more than the 100 milligram dose. As such, if you were to prescribe the lasmiditan, I would recommend prescribing the 100 milligram dose and then increasing the dose if you need further benefits. However, what the studies did see was a dose-dependent adverse drug event of dizziness and drowsiness. As such, if it warrants it, we should decrease the dose to 100 or even 50 milligrams if our patients are experiencing too many side effects. Next, I would like to talk about the prophylaxis of migraines. Who gets prophylaxis? Well, patients who get reoccurring migraines with significant disability should get prophylaxis. Furthermore, if they have frequent attacks of 2 or more times a week, they should get prophylaxis. And lastly, if they have tried all of the acute treatment and it's either ineffective, contraindicated, or produce serious side effects, now we can think about giving a prophylaxis treatment to prevent the occurrence of the next migraine. So what do we give? The most evidence for the prophylaxis of migraines are behind CGRP antagonists. That's your Aimovig, your Ajovy, and your Gality. Select beta blockers such as propranolol, metoprolol, and timolol. Select antidepressants, which are amitriptyline and venlafaxine. And select anticonvulsants such as valproic acid and topiramate. However, if none of these are effective, we have some refractory options, and these include NSAIDs, riboflavin, magnesium, and feverfew. All of these medications have limiting or conflicting evidence behind them, and we resort to them if we're out of options. This diagram shows our algorithm for picking prophylaxis, and the big takeaway point from this diagram is to assess your patient's comorbidities. For example, if your patient has hypertension or angina, a beta blocker is most likely your best option. Or if your patient has depression or insomnia, a tricyclic antidepressant may be your best option, and so on and so forth. The only medication not on this diagram is your CGRP antagonist, and that's because this diagram was produced before the invention of CGRP antagonists. So now let's go into CGRP antagonists. All CGRP antagonists are subcutaneous injections, and they work by modulating the CGRP receptor to decrease that trigeminal vascular pain transmission. They're all indicated for prophylaxis, and there's very limited data in special populations, such as children, elderly, pregnancy, and lactation. There are 3 CGRP antagonists on the market, and these are your Aimovig, your Ajovy, and your Gality. Aimovig comes in a 70 milligram dose every month, or we can dose increase it to 140 milligrams for an additive benefit. Ajovy comes in a 225 milligram once a month, or you can do a triple dose of 675 milligrams every 3 months. Your Emgality comes as a loading dose of 240 milligrams, followed by 120 milligrams monthly. As you can see, the time to peak for each of these medications is 5 to 7 days, which is why these 3 medications are only indicated for the prophylaxis of migraines. What's interesting about this is when I was looking into it in December, there are 2 other CGRP antagonists that are in phase 3 clinical trials for the abortive treatment of migraines. And I would like to follow that and report it back to you if they do get approved for that treatment. The most common side effect for these 3 medications are injection site reactions. And as you can see, this is most common with Ajovy at 40 to 45%. Furthermore, Ajovy and Emgality should caution use in cardiovascular disease as they were not studied in this patient population. And lastly, Emgality has an added FDA approval for the prevention of cluster headaches, which I'll go over in a different slide. Presented are the clinical trials behind these 3 medications. As you can see, the clinical trials show the biggest benefit for the use of Ajovy at the 225 milligram monthly dose. However, this benefit was not statistically significant when you compare each medication with the other. And as such, if you were to pick an CGRP antagonist, the decision should be made based on what the insurance covers. Now let's go into common triggers for migraines. And as I've mentioned before, for the prophylaxis, we should be avoiding these triggers. Triggers include behavioral triggers, environmental triggers, food triggers, and medication triggers. What's interesting to point out is under behavioral triggers, we have fatigue, sleep deficit, and stress. So for all of you residents that are in the same shoes as me, we're all at a greater risk for migraines. And furthermore, my co-resident Ariel, who many of you guys may have known, actually indicate that I'm her migraine trigger. So maybe that's why she doesn't respond to me all the time. And with that, let's move into cluster headaches. Cluster headaches are the most severe form of headache. They're most common in men, and they usually occur in patients between the ages of 30 to 50. biggest correlation with cluster headaches are in patients who were tobacco smokers. So if you need one more reason to advocate the quitting tobacco, this is it. Episodes for cluster headaches are why they're called cluster headaches, because they come in frequent episodic events that occur daily for 1 week to several months. For the pathophysiology of cluster headaches, they're not completely understood. It may be related to a hypothalamic activation, or it may be related to an inflammation of the walls within the cavernous sinus. Potential causes of cluster headaches include trauma, smoking, and genetics. And cluster headaches are really easy to identify. If you see a patient in the clinic or in the hospital, they'll usually present with an orbital, supraorbital, or temporal pain. As I mentioned before, these headaches will come in clusters, which are very frequent but short-lived. Some patients may get up to 8 cluster headaches a day. And most of these patients will present restless. They'll be pacing around the room, some will be rocking back and forth, and these headaches are severe enough that some people actually commit suicide. For the treatment of cluster headaches, first we want to think about abortive therapy. However, since these headaches are short-lived, the mainstay of treatment is to prevent reoccurring attacks during that cluster period. For our treatment of cluster headaches, we have our non-pharmacologic and our pharmacologic options. All patients should be placed on an 100% O2 non-rebreather mask. Furthermore, you can add on a pharmacologic option such as triptans, dihydroergotamine, lidocaine, and octreotide. Triptans, you want to use a medication that has a quick onset, so something that's intranasal or subcutaneous, and that limits you to sumatriptan or zolmitriptan. For dihydroergotamine and lidocaine, you want to provide it in an intranasal formulation. And for octreotide, this comes in 100 milligrams subcutaneous dose for cluster headaches. For the prophylaxis of cluster headaches, this is always recommended once the cluster headache period has been isolated. Treatment options include verapamil, prednisone, Emgality, and lithium, and these 4 medications have randomized control trials supporting them. Depakote, topiramate, and occipital nerve blocks are next-line options, which still have great data behind them. First, let's go into verapamil. Verapamil has the most evidence for use. Verapamil in clinical studies have shown to decrease the median number of attacks in not only the second week, but also the first week. It comes in a 120 to 160 milligram starting dose 3 times a day. However, a lot of these patients will require up titrations to even 320 milligrams 3 times a day. The biggest side effect, as you can imagine, is hypotension and bradycardia, which is why most other patients are put on verapamil. Due to the hypotension and the bradycardia, they can even experience dizziness and fatigue. Next, we have prednisone. Prednisone can be taken concurrently with other prophylactic medications. Prednisone has shown a decrease in pain and the frequency of headaches. I tried to find literature to state a guideline for the use of prednisone, but this is mostly prescriber specific. The dosages that I found were between 50 and 80 milligrams for 10 to 12 days. And since you're using such a high dose for such a long duration, I would always recommend using a taper. The biggest side effect for prednisone is insomnia, hypoglycemia, dizziness, and headaches. Lastly, we have lithium. Lithium has conflicting evidence behind it. However, in the randomized control study, it showed a decrease in median number of attacks in the second week. You start lithium at a 300 milligram dose 3 times a day. However, it requires therapeutic drug monitoring, which is another reason why I caution its use. Its biggest side effects are associated with toxicity, which include confusion, dizziness, and blurry vision. And with that, I would like to briefly go over medication overuse headaches as my last topic. Medication overuse headaches kind of fall under its own category. These are headaches that occur for more than 15 days a month, and they're also caused by an overuse of medication for more than 3 months. The biggest culprits for medication overuse headaches include opioids, butalbital-containing products, caffeine, and simple analgesics. Medication overuse headaches can even lead to chronic dependence. They present differently based on the medication. For ergots, analgesics, barbiturates, and caffeine, they present in a tension-type headache presentation. However, for triptans, these present in a migraine presentation. The treatment for medication overuse headaches is to stop the medication. However, based on how long they use it and how much they use it, I would commonly recommend using a taper. We've all had that caffeine headache that occurs when we suddenly cold turkey caffeine. I like to bring one interesting study that I saw about medication overuse headaches. Begal and colleagues looked at the biggest culprits within their organization and found that butalbital-containing products cause the highest incidence of medication overuse headaches. As such, for mild to moderate severity headaches, I would highly caution the use of butalbital-containing products, especially in headaches such as tension-type headaches. And with that, I would like to bring up the summary. For the treatment of headaches, we want to first consider non-pharmacologic options and then pharmacologic options. For the prophylaxis of headaches, we want to identify triggers and remove them, and if that doesn't work, we can also provide pharmacologic options. Now, does anyone have any questions?